So now we will change the topic, and I will introduce this next session with to discuss about morbid obese patient. First of all, we know that there is a relative risk higher in colon and rectal cancer in patients with BMI higher than 30. So that means it's obese patient, and we know that in the overall population there are more and more obese patients. That means that in the future we will have more and more obese patients to treat in colon or rectal surgery. The first paper published, in the beginning of this century with the arrival of this obese patient, and what authors reported? They reported that in obese patients you have an increased risk of postoperative morbidity regarding leakage, regarding bleeding, and regarding the reoperation rate. So more recently, with this meta-analysis, we can see that in obese patients we have a higher conversion rate. We have as well a longer operative time. And at the end, we have a higher morbidity. So you have to keep in mind when you will operate an obese patient that you probably have to convert the patient. The operative time will be longer, and the morbidity will be higher as well. This paper just published this year is really interesting because authors give us the critical point, and the critical BMI for the rectum is 30, whereas for colonic reduction is 35. That means that this is the cross point between the rate of attempted laparoscopic surgery and the rate of laparoscopic conversion. We published a few years ago in Bordeaux our results for obese patients or for patients according to BMI. And you can see that there is a linear accordance between the BMI and the conversion rate, whereas there was no difference regarding mobility and surgical mobility in our practice. But at the end, what is really important is that there is no difference at all regarding overall and disease-free survival in patients with high BMI. But this is before we discuss about BMI only. Now we have new publication, and we discuss about the repartition of the fat tissue. And in this paper, it's already 10 years ago, you can see that there was no difference regarding operative time if you consider the BMI, like in our trial, in our study. But if you consider the visceral fat repartition, there was a significant difference. And more recently, you can see that the visceral fat tissue is higher in male and in older patients. And in this paper, there is a significant difference regarding disease-free survival in patients with fat visceral repartition. The other thing for rectal surgery is probably the intertuberous distance, the mesorectal fat, and the BMI as well. That means that regarding colon and rectal surgery, you have to consider not only BMI, but you have to consider as well the repartition of the fat tissue, and you have to consider the anatomy, the pelvic anatomy of your patient. Then, these are the main issue in laparoscopic approach for rectal cancer. This is obese patient, this is narrow pelvis, and this is tumor location. And maybe that robotic approach or transsacral approach will fix this main issue. Regarding the robot, we have the answer, because we know, thanks to the rollout trial, that there is no difference if you take the overall population. But if you have a specific look on patient with male and obese patient, you know that there is a higher conversion rate in the laparoscopic group compared to the robotic group. So maybe it's interesting for this subgroup of patients. Probably we have to improve our surgical tools as well to take care of this patient with specific camera, specific port, and there is a lot of things that we can improve in this way. I discussed yesterday about the difficulty of perform coloanal anastomosis or low colorectal anastomosis with a side-to-end anastomosis, and specifically in obese patients, it's true just for feasibility. So, in conclusion, for obese patients, the situation will be more and more frequent. We have to assess not only the BMI, but the repartition of the fat tissue and the anatomy of the pelvis. Interest of robotic and Tati-Ami approach have to be assessed, and the impact on low anastomosis we discussed yesterday for these patients. Maybe it's convenient to perform delayed coloanal anastomosis, specifically in obese patients. And I take the opportunity to invite you in our masterclass, international masterclass in Bordeaux, organized with Professor Roudier. Thank you very much.
Thank you very much. Very interesting and very comprehensive talk. Are there any questions? No questions?
So, just a comment.
Okay.
How do you tackle the problem of the obese patient with the middle rectal cancer, which is actually the most difficult in dissection and transection if you try to do it transabdominally and not transanally? So, how you design the approach?
Without transanal approach. You ask me without
transanal. You
So we don't have the robot, and we move to the transanal approach. So now we perform synchronously transanal approach and abdominal approach. And probably that in obese patient with two experienced surgeons, this is the way to move on, because you can reduce the time of operation, and probably you have an easy, mesorectum dissection, because you just have to join both. And if you have two experienced surgeons, it's probably easy. But you can do it only if you have colleagues, if you are in a big center.
And at which point approximately the two groups meet inside the pelvis?
Anteriorly, it's quite, you follow the plane and you open the Douglas pouch. Posteriorly, this is a junction between the rectal and the horizontal part of the mesorectum. Transanally, you don't have to move away the horizontal part. So you just join at this level, and we remove the specimen transabdominally, never transanally.
Okay. If there is any other question, I can move to the next
Thank you very much.
Thank you very much.